Okay, so I think we'll get going. Hopefully you can we'll see my slides and hear me okay. So thank you so much for joining us and welcome to this webinar on the 1958 National Child Development Study at age 62. And we're very excited to share this new data with you. There's so much that's been collected in this sweep, and we'll try and give you an overview. So I'd just like to start with a bit of housekeeping. We are recording the content section of this webinar, but not the question and answer session at the end. So the recording, it will be available at a later date on our website and also on our YouTube channel. Your cameras will be switched off and mics muted throughout. And if you have a question, please use the chat function, and please note your questions will be visible to all attendees, and we'll try and answer your questions at the end. If you have any technical issues, please email us at ioe.clsevents@ucl.ac.uk. And most importantly, your feedback is really important to us. And we're continually trying to improve our training to help people understand and use the cohort data. So if you could complete the very short feedback form, the link will appear near the end of the webinar. Your views, they're greatly appreciated. So thank you very much. So introductions. So I'm Vanessa Moulton. I'm a researcher at the Centre for Longitudinal Studies, and I'm kicking off. And then Carol Sanchez will follow. She's the NCDS survey manager. And in the last 15, hopefully 20 minutes, we'll be joined by Sam Parsons, also a researcher at CLS, and George Plobidis, who is director of the NCDS, in the Q&A session at the end. Plan for today. So to start, I'm going to give a very quick overview of our cohort studies and the NCDS, along with some available resources, and then how to access the data. Then give you an overview of what's in the NCDS at age 62. And then Carol will cover methodology, so things about fieldwork and some other aspects. And we'll have, as I mentioned, a Q&A at the end. And again, please put your questions in the chat, and we'll hopefully be able to respond to those. So here at the Centre for Longitudinal Studies, we have 4 core cohort studies. The first, the National Child Development Study, so obviously that's the study of interest today. They were born in 1958 in Great Britain, so that's England, Scotland and Wales, in the same week, and the initial sample was around 17,500. The other 3, the 1970 British cohort study, again born in the same week in Great Britain. We have around 17,000 participants for that study. Next Steps, who were born in 1989 to 90. This study began when they were aged 13 to 14 and was initially run by the Department for Education up to age 20. It's England only and has just under 16,000 participants. And then the Millennium Cohort Study. They were born in the UK from 2000 to 2002 and have around 19,000 participants. Just to mention, there are also 3 other longitudinal studies we run here with younger cohorts. So if you're interested in that, please visit the website. All of these studies are ongoing. This chart shows the year on the horizontal and the age on the vertical. And the larger dots refer to periods of main data collection. So the NCDS, it's the oldest cohort we run. And since 1958, there have been 11 main data collections, excluding the COVID surveys. And by the end of this month, hopefully the last available collection, the age 62, will be available. The BCS 70, since 1970, there have been 10 data collections, including the most recently available age 51 survey. Next Steps from 2004, inclusive. Data was collected every year for 7 years until they were age 20. And since then, there have been 2 sweeps, the age 25 and the very recently available, the age 32. And finally, the MCS, including the first data collection at 9 months, have 7 sweeps. The last at age 17, the age 23 survey will be available at the back end of this year. Just to also mention, there'll be new data collections for the 1958 NCDS and also the 1970 BCS 17 next year in 2026, when they're age 68 and age 56 respectively, and the questionnaire is being developed as we speak. So there's a vast amount of information that's been collected about the cohort members across the life course. The content is multidisciplinary, it spans social, economic, psychological and health, and these are some of the topics covered, and there have been many scientific papers and policy reports that have been written on these areas. So I'm going to give you a brief overview of data collection in the 1958 National Child Development Study. As I mentioned, in total, including birth, there are 11 sweeps of the study currently available, and very imminently 12 with the age 62 sweep. In the early sweeps of the study, the main respondents were the parents, particularly the mothers, and at age 16 there was more involvement from the cohort members themselves, who became the main respondents from age 23 onwards. This study began as a perinatal mortality study, so the early focus was medical. And in all the childhood sweeps, there are medical examinations and other information was collected from schools, for example, how the child behaved in school and their examination results. We also have things like height and weight, which has been collected at most sweeps, and a biomedical sweep at age 44, including blood samples to extract DNA. And 20 years on now, we have the new biomedical sweep at age 62. Cohort members also sat a variety of cognitive and mental health tests in childhood and adulthood. There's a variety of linked geographical data available, and consent has been asked for health and economic records, which will soon be available. The number of participants taking part in each sweep is shown at the bottom. And you can see that the number has fallen, from 17,400 has been gradually dropped over time. So in the midlife, it's around 9,000, with around 8,400 for the current age 62 survey, which is amazing. And Carol will talk a bit more about this later. So the main survey is also enhanced by other types of data. So for the NCDS, we have genetic data for around 6,300 cohort members, and further information can be found on the link on the website. And also there's a genetics GitHub site, which gives a lot of information. And just to mention, soon to be available are polygenic indices across 44 traits, which is amazing. The linked administrative data is available. So we have hospital episode statistics in England and Scottish medical records, and coming soon we will have employment data in England via the UK Longitudinal Linkage collaboration. We also have geographical data available, linked from the cohort members' postcodes, for example, local output areas and the Townsend Index of Deprivation. And if you're looking to conduct cross-cohort analysis, some data has been harmonized across different cohorts. So, for example, we have socioeconomic data, we have BMI, mental health, and soon to be available, we have data on asthma and diabetes, which has been harmonized. And also we're looking to harmonize data on cancer and partnerships and fertility data. So all these areas that I've mentioned, they're key areas of program development and expansion here at CLS. Just to mention, we also have COVID online surveys conducted at 3 time points, 2 in 2020 and a third in 2021. And the surveys investigate possible impacts of the pandemic on multiple aspects of life and covered a wide range of subjects. And these are embedded in the main survey data, so are unique compared to most surveys, because you can look at data pre and post COVID. So where do we go for more information about the NCDS? So most of what we're discussing can be found on the CLS website, which has extensive resources and information. There's an overview of the NCDS study, each of the sweeps, sub-studies, documentation, latest research, and it's definitely a great place to start. And there's also an introduction video on the NCDS, which gives an overview of the last 11 sweeps, not the new one. There are user guides available for most studies covering fieldwork, overview of study content, data, etc., technical reports written by the external fieldwork agencies, and the questionnaires are all available. There are also other specific user guides for linked data, such as administrative health data, the COVID-19 surveys, and guides on using the data. So, for example, handling missing data. And we also have a training and support page on our website where you can find previous webinars on a variety of topics. So, for example, introductions to each of our studies, methods, themes such as aging, mental health, specialist data such as genetics, etc. And these are also available on our YouTube channel. On the website, you can search for upcoming events, and we run a wide range of events throughout the year. So next up is a training event on polygenic indices, and that will be on the 30th of September, which discusses the soon to be deposited polygenic data and how you might use the data. In the autumn, look out for other events. So, for example, handling missing data in the MCS, a webinar on causal inference, and if you know anyone who is new to the cohorts, our Getting Started webinar, which gives a basic introduction to our cohorts, contents, analysis, and handling the data would be useful. So how do we get access to this amazing data? Well, most of the data, cohort data, is available via the ukdataservice.ac.uk. It's free to download for students, academics, government analysts, and the third sector. And access for most of the data is immediate. If you haven't already, you'll need to register, complete a few sections about yourself and what you're using the data for, a really small abstract, and most of the data can be downloaded instantly. As we'll show, there's a wide range of data available, and it goes through a process of classification based on sensitivity and disclosure, and it's grouped on various levels. And most data has been classified as low level of sensitivity and is licensed under the end user license. So basically, all this data, as described, you can apply directly to the UKDS data service, and you can download the data directly from there. Other data, for example, special license, that's moderately disclosive. So for example, geographical indicators, you would again apply via the UKDS, but you would need CLS to us to approve it. And the most sensitive data or disclosive is available under secure access license. So for example, things like linked health data. You can find out more about access to other more sensitive data, including genetic data, if you go to the CLS website access page. So this is the page to access the NCS data from the UKDS, and the age 62 data will appear here, and we're hoping it will be here next week. I would recommend using the serial number for the NCDS cohort, which is 2000032, which will help navigating all the NCDS data available. And if you use this series link and then click on access data, it'll show you all the different types of data available for the cohort, and it's kind of nicely summarized into various areas. When you download the data, you'll also get helpful resources. There is a user guide and questionnaires, a variable lookup table, and technical report. And we would strongly advise looking at the user guide. It explains the fieldwork, the questionnaire, response to the survey, the data, for example, things like identifiers, derived variables, and non-response weights. And much of what we'll be highlighting now can be found in more detail in the user guide. So let's have a look at the content of the age 62 survey. So I'm going to cover a number of areas: economic, physical health and biomedical data, mental health and well-being, cognition, and highlight a few specifics and special features. However, just to say, this isn't exhaustive and is an overview to give you an idea of what's available. So first I'll focus on economic activity, income and wealth, and these charts generally follow the same pattern. I'll show you when these measures were collected on the left-hand side, and in the right-hand column the focus of today at age 62. And everything on this slide has been collected in the current sweep. So age 62, we capture the cohort members' economic activity status. If they're economically active, they were asked to provide details about their current job as well as any previous jobs they had since last interview. If the cohort member is cohabiting, has a cohabiting partner, the partners were also asked to provide details about their partner's jobs, and these were coded to the 4-digit standard occupational coding SOC 2020. 3 digits are included in the main data, along with measures of social class, so the NSEC classes 5 and 7. Occupation of the parent and then the cohort member has been measured at most sweeps, and we have data on employment histories across the life course. Cohort members and partners' earnings were also measured again. Also income from other sources such as benefits, investments, etc. was measured at age 62. And we also captured wealth. So housing wealth, we have house value and mortgage, their financial wealth, savings and debts. And the Department for Work and Pensions, the UK government department responsible for welfare, pensions and child maintenance policy, were co-funders for this sweep. So there's extensive sets of questions on pension provision and retirement, which I'll discuss in a bit more detail in a minute. We also ask about inheritance. So have they received or their partner received an inheritance, the number of inheritances, who received it, who they received it from, the value and when. There are also questions on expectations of future receipt of inheritance, and they were also asked about receipt of substantial gifts, so more than £1,000, how many, who from, value and when. And also transfers given, so over £1,000, so the number up to 3, who to, the value, when and what for, and also if they give regular financial help to others, who, how much, and frequency. Okay, so as I mentioned, there's a comprehensive set of questions on pension provision. First, cohort members are asked if they belong to any pension schemes and the number that they belong to. And for each pension, up to 6, there is a series of questions around that particular pension. So is it an employer or a personal pension? Is it a defined contribution? So for example, their fund grows over time, or is it a defined benefit pension? So basically underwritten by the employer, for example, final salary pensions, which are far more secure. It gives you a secure pension for life. They're also asked questions on contributing to, who is, additional contributions they've made, and for the defined benefit pensions, whether they're currently receiving it, when they received it, the last payment, and whether they've taken a lump sum, and if they haven't taken it, when they expect to, the expected income that they think they'll get from it, and again, whether they've taken a lump sum. And for the defined contribution, whether they've withdrawn, the type of access that they've withdrawn the defined contribution from, when and how much, current value, when they intend to do so, and if they intend to do so, and when. There's also questions on partners' pensions if they're cohabiting, which follow a similar line, but not as detailed. When interviewed, this cohort were pre-statutory pension age, which for them is age 66, and the cohort members, and also information about their partners, was asked about their state pension. So do they expect to receive it, and at what age and how much they expect to receive. There are also a number of questions asked about retirement. So for those fully retired, both cohort member and their partner, we ask reasons for taking retirement, and also in the self-completion questionnaire, there are a series of questions specifically about retirement. So if they have retired, what age they retired, if they haven't, the age they'd like to, and also the age that they would expect to retire from full-time employment, and then the same questions for all forms of paid work. There are also some questions around expectations. So they were asked to rate these from 0 to 100% in terms of expecting these things to happen. So for example, age that they'll live to, 75 or more, 85 or more, whether they'll be working after age 66 and age 70, whether health might limit their ability to work before age 66, and sometime in the future, do they think how do they expect not to have enough financial resources to meet their needs? So moving on to physical health, there are a mixture of physical measures in the NCDS. The age of objective and self-reported. The age 62 sweep, as I mentioned, is a biomedical sweep, so has more objective health measures than other sweeps, apart from the age 44, which was also a biomedical sweep, and then perhaps the early medical sweeps in childhood. So starting with some self-reported measures, there's a measure of self-rated general health, as well as the ONS questions on long-lasting health conditions and illnesses. Also, particular medical conditions are identified and a range of physical activities. There are also self-report questions relating to health behaviours such as diet, smoking and alcohol consumption, and sleep, and established scales such as the 5 items from the audit PC, which measures alcohol consumption, problems and dependencies. There's also a section on COVID-19, so whether they had that, whether they had vaccinations and type, whether they have any new conditions as a result of COVID, and also some questions around long COVID. And before looking at the objective measures collected, another key element of this sweep was the drug coding of prescribed medications. So during the health visit, the cohort members were asked, are they taking or using medicines, pills, syrups, ointments, puffers or injections prescribed by a doctor or nurse, and any long-acting medications such as injections or implants. And the name of each medication was recorded, and where possible, the interviewer asked to see the packaging. Each medication was coded to sub-chapter level 4 digits of the British National Formulary. So let's have a look at the objective measures. So this slide outlines objective measures relating to anthropometry and other physical functions. So during the health visit, we collected height and weight, waist and hip circumference, body fat, blood pressure, pulse, grip strength, leg raise balance, and timed normal walking speed. And the protocols for each of these measures is outlined in the user guide. We also have some measures, and these are self-reported, on vision and hearing, and also age 62, the number of teeth that they had. During the biomedical sweep at age 62, and also at age 46, as I mentioned, blood samples were collected by the health visitors. And if they consented, 5 tubes of blood were taken, 2 tubes were used for biochemical analysis, and the study extracted total and HDL cholesterol, triglycerides, C-reactive protein, glycosylated hemoglobin, and insulin-like growth factor. And these identify fats and proteins related to inflammation, sugar, and hormones in the blood. Also new to the study, we had 3 cardiovascular health measures, troponin I, NT-proBNP, and GDF-15, and more details on these are in the user guide. And just to point out, there is actually a specific biomarkers data set if you're interested in that. As well as the biomarkers discussed, metabolomics analysis was conducted. Serum samples were available for just over 5,000 cohort members, and 250 biomarkers were quantified. So, for example, things like total and other lipids, lipoprotein and subclasses, fatty acids, amino acids, and ketone bodies. And if you're interested, there is a separate user guide outlining the metabolomics, so things like extraction, curation, data set description, and how the data was dealt with. Another special feature at age 62 was the Oxford WebQ, which is an online dietary questionnaire completed on one random allocated weekday and one weekend day about their consumption of food and beverage items in the previous 24 hours. And this was conducted 7 days following their interview. This allows for measures of nutrient intake to be calculated, and this data isn't yet deposited but will be available later in the year. Now we'll look at cognitive measures at age 62. We repeat measures that were asked at age 50. So there's 4 cognitive measures: immediate word list recall, animal naming, letter cancellation, and delayed word list recall. And these measure memory, executive function, and processing speed. Moving on to mental health scales, of which there are a few. In adulthood, the primary measure in the NCDS is the malaise inventory, which measures psychological distress and has been measured again at age 62 using the 9-item scale. The mental health inventory is a shortened version, 5 items, of the general mental health questionnaire in the SF36, the short form health survey. And this is often used as a screener for mood and anxiety disorders. Also, there's 2 items from the GAD, measuring general anxiety disorder, and 2 items from the PHQ, which measure frequency of depressed mood and loss of interest and pleasure. In addition, there are also measures of well-being captured at age 62. We have the short version of the Warwick Edinburgh Mental Wellbeing Scale, 7 items of this, the life satisfaction scale, and quality of life scale, which 6 items which measure 2 domains, control and self-realization. And new to the NCDS, main sweeps loneliness was measured using 3 items from the UCLA loneliness scale. Some other question areas we wanted to highlight were questions covering family and relationships. So we have the social provision scale. There's 3 items from that, which measures the availability of social support. We have information on non-cohabiting relationships. There's more detailed information on the cohort members' children's lives. So, for example, frequency of contact, their housing tenure, economic activity, highest qualification, and marital status, which is amazing because now we've got 3 generations of information, socioeconomic information. Also, grandchildren, if they have any, their age, do they look after them, and frequency, and their own parents and their partners. So are their parents alive and their partner's parents alive, frequency of contact, the type of help they give them, and the number of hours. And also there's some questions on immediate family. So they are that they're not actually living with. So do they have contact with them and frequency? So we also collect information on lifelong learning, so any types of new qualifications gained, both academic and vocational, since the last time that was collected, type of leisure activities they take part in, so for example, walking, swimming, DIY, gardening, etc., the frequency that they do this, and the average time per occasion. We also have some information on activism, so have they taken part in a rally, for example, or signed a petition? We have a number of questions on attitudes and opinions on things like politics, race and class, and also participation in organisations such as social clubs and political parties. And then finally, religion. So are they practicing, and their attendance at religious services. And finally, regarding the content, a new special feature at age 62 was the life history questionnaire. And this asked questions about health, education and family life when they were age 7, 11 and 16, which is the equivalent ages for the previous sweeps in childhood for the NCDS. And it covers a number of areas: accommodation, parents' economic activity, health behaviours, feelings and behaviour, relationship with parents, specific events, so for example, bullying, parenting, or so whether a parent or a sibling died, separation from the parent and more. And just to finish on a more positive note, activities with the mother and father when they were younger. Okay. So I'm now going to pass you on to Carol, who will discuss some methodological aspects of the age 62 study. So I'll stop sharing and let Carol share.
Hopefully these are sharing now, but please do let me know if there's any issues with that. So I just want to... Oh, great, thank you. I now just want to talk through a bit about the methodology we used for the age 62 survey. So just to provide a brief overview to begin with, so the age 62 survey includes a number of elements. We have a main interview. So, the survey overall comprises of 3 components. We have a main interview, a follow-up health visit, and 2 self-completion questionnaires. In total, from this, we have deposited interviews. We've deposited 8,405 interviews, and that's a response rate of 73%. We have had a considerably long fieldwork period due to the pandemic, and the survey was originally designed to be an in-person survey and was first launched in 2020. But due to the COVID pandemic, we had to pause interviews and make adaptations to the script in order to introduce a video interview mode. So the pandemic did have had an impact on not only on fieldwork, but also on our interviewer capacity, which caused further extension to the fieldwork period. So the main stage interviews finished in 2023, and a short mop-up web survey was sent out in early 2024. I'll now just quickly run through the different stages of the survey and the modes of interview that was used. So as I previously mentioned, prior to the pandemic, the survey was designed to be a large-scale in-person survey. And because of this, the pilot, the dress rehearsal, and the initial main stage, which ran from January to March 2020, these were all conducted in this way in person. But when we had to pause fieldwork when in-person interviewing was not feasible, we adapted the script and conducted a video interview pilot, which was a great success. And due to this, we were able to relaunch the video as a video-only mode between November 2021 and April 2022. And in this time, we were not able to conduct any of the health visits, as these had to be done in person. So from spring 2022, we were able to switch back to our in-person interviewing, as this being our preferred mode of interview, and we were able to restart health visits. When we moved back to in-person first approach, we did continue to offer video call interviews for those who requested it. We also used a video call mode for cases where there was not an in-person interviewer available in a particular area, so they were able to do it by video call instead. So we finished in field at the end of 2023, and after this we conducted a short web mop-up survey, and this was done in order to boost our overall response. But those who took part in this mop-up survey were not followed up with a health visit, but I'll talk about that in a bit more detail as I go through. So now I just want to talk through the fieldwork overall and the steps that were involved. I'm just going to focus at this point in time on the main core interview, and I'll just discuss the mop-up a bit later on. So we had a sample of 11,493 cohort members. That was our cohort that were born within 1 week in 1958 and were known to be living in Britain. And these were issued to our pilots, our dress rehearsal and the main stage. We sent out a letter and booklet providing further information to our cohort members on the survey, and then the interview made contact to book an interview. And when the interview date was agreed with the interviewer would provide participants with the self-completion questionnaires to complete in advance of the interview. So these were either provided in person if they were in touch with them prior to the interview, or they're provided by post. So an interview was conducted either in person or by using video, which was done by Microsoft Teams. So overall, from both the main stage, the pilots, and the dress rehearsal, we completed 7,809 interviews. In terms of the paper questionnaires returned, we had around 7,000 cohort members that returned their paper questionnaires. For a video call, these had to be posted back. For an in-person interview, there were a number of opportunities to collect these questionnaires. The interview would ideally collect them, the completed questionnaire at the end of the survey, or they could be collected after this in the health visit by the healthcare professional, but there was also the opportunity to post these back as well. So at the end of the main interview, participants were asked if they'd be willing for a healthcare professional to contact them to arrange for a health visit to take place. And we did have a high agreement to this, with 92% agreeing to be contacted. In normal circumstances, the healthcare professional would be in touch within a few weeks of this main interview. But due to the pandemic, there was a bigger gap between these stages, because there was periods when these visits weren't able to take place due to not being able to contact them in person. But we also had capacity issues with our healthcare professionals, which did cause delays in some of these visits. We were able to conduct 6,309 health visits. Just to mention, these are also referred to as nurse visits. So a number of these took place, and which a number of biomeasures were taken, which I'll discuss shortly, but won't go into too much detail as Vanessa has covered this in her presentation. So this was also the stage. It was a health visit when participants were asked if they'd be willing to complete an online dietary questionnaire on selected days. So during the health visit as well, if permission was given, blood samples were taken and sent to the labs for analysis. And participants were actually provided with some of these results as part of their thank you, their letter. So this was an incentive for many to take part. Now I just want to move on to discuss the questionnaire. So the main or the core questionnaire, so that includes the questionnaire in the pilot and the dress rehearsal stages as well. It covered a number of elements. We had cognitive testing. So as Vanessa mentioned, this is immediate, delayed recall, animal naming and letter cancellation. We had a block of sensitive questions. These were completed either by computer-assisted CASI interview, and this took place if the interview was in person, or for those who took part by video, the section of the questionnaire was completed by a short web survey. We also asked for consent to data linkage. So following the pilot, the dress rehearsal and the initial main stage, there were some adaptations made to the questionnaire. But the data does include all these stages unless a significant change was made to a question. And you can see in the data, if a question was not asked in a particular stage, there is a code which indicates that this was the case. Just to mention, the data will also include some partial interviews and a small number of cases where the interview was conducted with a proxy. Vanessa Alex has already mentioned the questionnaire, so this is just, the paper questionnaire, so this is just a brief recap. So as I mentioned, there were two paper questionnaires. They were provided by the interviewer either in person or by post in advance of the main interview. We did initially provide only the Your Life Now paper self-completion in advance of the interview, and the childhood questionnaire was provided at the end of the interview to be collected at the health visit. But when we introduced video interviewing, it's decided to provide both of these questionnaires in advance, and this actually had no impact on our overall response. We actually had a very good response overall for both questionnaires. We had 90% returning the Your Life Now questionnaire, and a slightly lower response, but still high, of 86% returning the childhood questionnaire, which is also known as a life history questionnaire. Now just to briefly touch on our health visits, we have data from 6,309 health visits. And as Vanessa mentioned earlier, this covers a number of things. So we have drug coding of the prescribed medications, we have blood pressure, both sitting and standing, grip strength, waist and height circumference, weight and body fat percentage. We have blood sampling, DNA and assays, and this depends on the permission that was given at the time. We have timed walk and we have balance measurements. And at the end of this health visit, there was a link given to the online dietary questionnaire. And I just want to move on to talk a bit about the mop-up stage. So this took place after the main fieldwork had finished, and it included three main sample groups. So the first group we term our non-responders. So in order to boost response, we invited all those who were invited to the main stage, that also any dress rehearsal or the pilot, and for those that didn't take part at this stage, they were asked to complete the shorter online survey. And we had 406 people take part from this particular group. We also invited cohort members living outside of Great Britain, which we refer to as an immigrant sample. They'd not previously been invited to take part in the main survey or any pilot or dress rehearsal, but they were asked to take part in this particular stage, and 190 people did, and that was a response of 58%. We then have this final group, which we refer to as our pre-COVID responders. So we decided to invite participants who took part in the main stage, or it would possibly be in a dress rehearsal or pilot, but they took part prior to the pandemic lockdowns. So we asked them to take part for a second time. So this was a valuable opportunity to see how things had changed for them pre and post-COVID. It also meant we were able to ask them some of the COVID questions, which were added to the survey at a later date. So we had 1,046 people who took part for a second time, and we had a response rate of 65% for this group. So by adding this particular mop-up stage, we were able to achieve 596 additional interviews to our overall base, and we're also able to achieve just over 1,000 interviews from 2 time points. So the mop-up questionnaire was considerably shorter than the main questionnaire. It was around 25 minutes long, and it was administered by web. So the main questionnaire, just to note, was around an average of 90 minutes long. So this was considerably shorter. So the partial interviews have been included in the data, but we didn't have a proxy interview option at this stage. The mop-up did not include the additional elements, such as we didn't have cognitive assessments. We didn't ask them for consent to data linkage. While we didn't have a section covering sensitive questions, there were some key questions we did maintain for the mop-up survey. Participants taking part in this stage weren't asked if they'd be willing to have a follow-up health visit, so as such, they were not asked to complete an online dietary questionnaire. The participants in the mop-up were also not provided with the paper questionnaires to complete, but we do have some cases that did complete a paper questionnaire and are included in the data. So these are cases which were first invited to take part in the main stage pilot or dress rehearsal, but didn't take part at this particular point. But they may have received the questionnaire and still have completed it. And then they later took part in the mop-up survey. So I just want to look further at how the mop-up data has been incorporated into the main data set. And there are two main suffixes I would like to sort of point out. So the one that ends with R2. So in summary, this is a variable which contains the mop-up data for those who took part twice, both in the main interview, or also when I say this, including the pilot and the dress rehearsal, and they also took part in the mop-up. So it indicates data has been received from 2 time points. So I've got an example here of the loneliness scale. So the variable without the R2 suffix, this variable contains data from the main or first interview if they've taken part twice. The variable with the suffix R2 is data from the second interview for those who took part twice. So this is their mop-up data. The second suffix to be aware of is MUP. So these are questions which were only asked in the mop-up. There are only a few of these, but these just highlight that they only contain the mop-up data. So the mop-up was added at the end of the fieldwork in order to boost our overall response. And I just wanted to highlight in this slide how it did increase the response. So overall, it did boost the response from around 70% to 73%. As you can see from this slide, this just shows how the sort of interviews have been built up, adding the main stage, adding pilots and dress rehearsals, as well as a mop-up. It just covers all these various stages and interviews achieved. This slide shows how the total interviews are broken down by mode. So the majority of interviews that took place in NCDS took place in person. So as I mentioned, the age 62 survey, it was a mixed mode design. And there are some differences in using different modes, which may influence responses between modes. These are known as mode effects. However, there can also be mode selection, which is the difference in responses between mode due to who is responding to each mode. So very briefly, accounting for survey mode is only necessary when response differences are a result of mode effects, that's measurement error. So the age 62 survey used a very similar approach to our 1970 British cohorts study, BCS 70. And findings from BCS 70 indicate that differences observed between in-person and video interviews are largely due to selection effects, that's the mode chosen, rather than mode effects, measurement error. So this suggests that mode-related measurement bias is minimal in BCS 70, and we would assume this is the same case in NCDS. But we do, however, plan to explore in NCDS the non-random allocation to survey by specific characteristics using statistical adjustment. And further evidence will be provided in the second version of the NCDS age 62 user guide later on in the year. But in the meantime, we would advise following guidance in the handling mode effects in the CLS user guide for further information. And you can also refer to the BCS 70 user guide as well for further information. So moving on to response in the survey. So longitudinal surveys, attrition is a fact, unfortunately, not just in our cohorts, but it will happen regardless of any procedures to minimise it. So here at CLS, we work very hard to encourage our cohort members to take part in the study. And in NCDS, the original sample was just over 17,000 at birth, and since then you can see a gradual decline. So around age 44, the sample was around 9,000 and just dropping to just below this in this recent survey. So with missing data, there is a potential for bias, as respondents are often systematically different from non-respondents. So there are a number of ways to deal with non-response to surveys. In NCDS, we use the rich data cohort members have provided across the live course to help restore sample representativeness. So one approach is non-response rates, and non-response weights, which I'll come back to. Another approach is multiple imputation. So further advice on dealing with missing data can be found in the link that's provided on the slide, and there's also a handling missing user guide and webinar which can be referred to. So in NCDS, we use non-response weights, and these have been included in the main data file and the biomeasures file. So our target population that we have is individuals born in 1 week in 1958 at the start of fieldwork, and we're alive and living in Great Britain. And response is conditioned on a set of covariates informed from the CLS missing data strategy. So the 3 weights are labelled on this slide that are in the main data. We have one for the main survey, and we have one for each of the paper self-completion questionnaires. We also have weights in the biomeasures data file, a main one, and a blood weight. For further information, you can refer to the user guide. So this, I just want to briefly show you an example. So this shows the effectiveness of the derived non-response weights in restoring sample representativeness. So here we look at the sample means of 2 variables, maths and vocabulary at age 16, and that's from the full sample of age 62 respondents. And we show that the target population, unweighted data at age 62 and the data when applying the non-response weights. And for both maths and vocabulary, there's considerable bias in the results of the unweighted data. However, when we're using the non-response weights, this is clearly reduced. So that has me come to the end, and we hopefully have time. We have 10 minutes for looking at any Q&As that you have. So I'm just going to stop sharing now. Thank you, everyone.